Our kidneys are the size of our fist and sitting at the back, and they are like a superhero filter. They are filtering our blood 24 hours a day, 7 days a week.
They filter your blood, so they remove any excess toxins. They're also responsible for maintaining your minerals such as potassium, calcium, sodium. It's very important. It also helps with making some hormones that helps to help your red blood cells. Okay, it also helps with your blood pressure management, and of course helps to get rid of any excess fluid or water. Chronic kidney disease is a long-term progressive loss of your kidney function. Typically, it occurs over months to years.
Chronic kidney disease means that there is a permanent damage to the kidneys that result in abnormal or off kidney function tests in separate occasions. And that does not only mean that the blood tests are abnormal, but also we look at the urine tests, and if these tests are positive for protein, that is also an indicator that the person may have chronic kidney disease.
Chronic kidney disease can affect everyone. All of us, some more than others, are at risk of kidney disease. The most common things that cause kidney disease, number one, is diabetes. Second to that is high blood pressure. Additionally, other things can contribute, such as our advancing age, as we all lose 1% of our kidney function every year, typically after age 50 with natural aging. Of course, having chronic heart disease as well can contribute. There are certain medications that we take commonly, over-the-counter pain medications like ibuprofen, naproxen, diclofenac, that can also contribute to progressive loss of kidney function.
There are some other kidney conditions such as polycystic kidney disease. There are other conditions such as age-related, sometimes even injury, trauma, as well as kidney stones. Another important cause of kidney disease is the inherited conditions, some of which are well known, such as polycystic kidney disease, and some of them are less well known but are increasingly being recognized. So it's important to have support from a genetic counselor. The good news is that a lot of these genetic tests, such as those that check for ApoA1 condition as well as polycystic kidney disease, are now commercially available and are being covered by insurance. So patients who have several family members who have had kidney failure, need for kidney dialysis or transplant, should get checked for these genetic conditions. It'll have an impact on how your health is managed. It needs to be treated possibly more regular or more aggressively. Every patient needs to have a detailed evaluation to figure out what is the cause in their individual case. The test that we do, typically we start off with taking a look at the picture of the kidneys with an ultrasound. The ultrasound is the same test that is done when women are pregnant. It's painless and there is no radiation exposure. It gives us a very good idea about the size of the kidney, if someone has any kidney stones or cysts, or if there is any other issue. So it kind of gives us a picture of the kidney and tells us what the kidney looks like. And this is slightly different than the blood test. The blood test tells us what the kidney function is. So we want to look at the kidney function in the blood test. We want to look at the picture of the kidney in the ultrasound or CAT scan. And then we also want to look at the urine test.
So when someone does a blood work with a primary care doctor, or a patient does a blood work at a primary care doctor, that includes the chemistry. It's a routine blood work. And if there is any abnormality in that blood work that is done, then it prompts the diagnosis of chronic kidney disease. And after that, we do repeat blood works just to make sure the numbers are correct, and we look at the urine usually to see if there is any blood in the urine, any protein in the urine, because that helps us also stage the kidney disease and tell us what's going to be the prognosis and the progression of the disease.
The urine test tells us what the kidney is actually doing. Is the filter working? If it's working, is it keeping the things that it needs to in the body? Or if it's not working, is it throwing out things in the body which it should not, which would be something like protein in the urine, it would be things like blood in the urine.
At the end, we collect all this information and we make a diagnosis of chronic kidney disease. Usually from the early stages of kidney disease, whether it's stage 1 or 2 or 3, or even 4, patients can present with no symptoms. Other than that, it goes back to the functions of the kidney. When the chronic kidney disease is more advanced, let's say within stage 4 or 5, you start having symptoms of dysfunctional kidney. And that means whether it's buildup of fluids around the body, whether it's buildup of the toxins, which can present with weakness, feeling depressed and feeling tired, losing appetite, losing weight, and of course the other electrolyte abnormalities such as very high level of potassium and phosphorus and abnormalities in calcium. But in general, the presentation is usually very subtle and it progresses over a long period of time.
It is a silent condition because in the beginning we don't notice anything. However, people begin to have swelling in the feet, people begin to have elevated blood pressure, sometimes they don't sleep well, their appetite goes down, people can also have itching, and other things which are abnormal are things like high potassium level in the blood, more protein or blood in the urine.
GFR, the word eGFR, it stands for estimated glomerular filtration rate, which is a fancy word, but basically what it represents is it's an estimated number that puts the person in one of the chronic kidney disease stages. So basically it's an estimated representation of the function of the kidneys, and the numbers change depending on the stage.
We are all born with about, say, 100 ml per minute, but then as we grow older or there are other conditions, then the GFR number goes down naturally with age. However, when people have conditions such as high blood pressure or diabetes, which are not controlled properly, or sometimes people are not even aware that they have these conditions, then the kidney function unfortunately goes down faster. And when it goes down faster than desired, then it goes below 60 ml per minute, or you could call it 60%. And when it's less than 60, then according to the National Kidney Foundation definition, people get what we call as chronic kidney disease. And that's why GFR is a very important determinant and a deciding factor. And we don't call it chronic kidney disease unless somebody's GFR is less than 60 for at least a 3-month period. For stage 1 and stage 2, which would be when the GFR is above 60, people have typically no symptoms. And this is when we would like to figure out if there is a problem. When people's GFR starts going below 60, these symptoms start appearing in stage 3. Stage 3 is divided into stage 3A, which is your GFR between 45 to 60, and stage 3B, which is worse, with GFR between 30 to 45. Stage 4, most patients who have stage 4 chronic kidney disease have these symptoms, and by stage 5, we are planning to initiate kidney dialysis, or what we call medically as renal replacement therapy. And the reason is because the toxin poison level in the blood is rising high enough that it leads to other symptoms, it leads to complications, and by this time it has become a serious problem.
We also have to look at the urine albumin stages. So we also give the classification of A1 if there's very little albumin, A2, that means the albumin stage that is moderately increased, and then A3 means that the person has a lot of albumin in the urine. When it comes to albuminuria stages, or the albumin in the urine as such, if it's less than 30, it's considered to be normal. This is in milligrams. And then if it's in between 30 and 300, it's considered to be moderately increased. And then if it's more than 300, then we think that the person has severely increased proteinuria.
The prevention begins when you're seeing your primary care physician, medical doctor, following your primary care doctor's advice, staying active, eating a well-balanced diet, not using tobacco or smoking. And then if you happen to have diabetes or high blood pressure, getting them under control.
Whenever anyone has kidney disease, the aim is to slow down the progression of kidney disease as much as we can, keep you with your native born kidney function for as long as possible, and try to extend the time period within which you would end up on dialysis. So the first thing you have to do whenever you have kidney disease is lifestyle changes. Very important. Okay, so this includes things like exercise, okay, ensuring adequate hydration, fluid intake daily, avoiding any medications that can cause damage to the kidneys, most commonly medications for pain like the ibuprofen, naproxen, diclofenac, okay? And then of course we have to control the illness that increases our risk of kidney disease in the first place, such as diabetes, high blood pressure, heart disease, okay? In addition, there are certain medications that are used depending on your stage of kidney disease and what's happening in terms of your urine, is there protein loss, and just having kidney disease in general, that can be given to help to slow down the progression of kidney disease. And these are medicines like empagliflozin, dapagliflozin, and of course our common blood pressure medications, which are usually the cornerstone, such as olmesartan, enalapril, lisinopril, losartan. So it's a combination of things, with lifestyle modifications being the cornerstone, right, or the benchmark, and then we add on medication management and of course controlling the illness that caused the kidney disease in the first place.
And then beyond that, we would like to do SGLT2 inhibitors. So these are new category of medications which have been out for a few years. And then losing weight or using GLP-1 medications, that has also been beneficial. And then we have some MRA medications, mineralocorticoid receptor antagonist medications, which are now available. Now the big issue here is we want to make sure that you are still following with your primary care doctor, you're still following with the kidney doctor. Typically when people are getting into stage 3A or 3B, then the visit may be every 4 months. Then if you go to stage 4, the visit could be as often as every 3 months. However, we like to do a team collaborative approach wherein we are working with the primary care physician. For many of our patients, their first interaction or meeting with a kidney doctor starts when they are actually in the hospital.
There is a subset of patients that do not know they have chronic kidney disease, or they're unaware about their other conditions, and eventually find out that they have severe or advanced chronic kidney disease once they feel the symptoms. Like I said, those come towards the end, and they end up going to the ER or going to the doctor, and when they get blood work or blood tests, they notice that the kidney function is already very advanced, and the kidneys are basically not working. The process of starting dialysis and the process of mentally accepting all of these changes is a lot tougher on people that do not get to prepare mentally and do not get to start to work towards getting this better from an early stage. because it's a sudden change and the person really gets a really, let's say, important lifestyle change when they have to start dialysis. So what we recommend is to get tests every year. Every person has to get at least a creatinine and an eGFR yearly, so that in case the person starts to develop chronic kidney disease early on, we can catch it and the person does not crash in the ER.
And this could be when they are getting admitted to the hospital in the summer heat, when they are dehydrated. Sometimes they have procedures done where they get intravenous dye, which is used for the CAT scans. Sometimes actually it's none of those, and it's like a side effect of a medication or even an antibiotic which they got. So that's when they meet the kidney doctor for the first time. For the hospital kidney doctor, getting to know all the details about what brought you to the hospital, what procedures you've had, is very important. And once they do a physical examination, then doing some additional tests, which may be more detailed than what we do in the outpatient setting, are important. However, we still do a blood test, a urine test, a kidney imaging test, and then we try to formulate a list of causes which could be the reason for the kidney failure. Typically, we work with the hospitalist doctor, the cardiologist, and the endocrinologist if someone has diabetes, and come to a point where one or two diagnoses are identified, and then we work towards mitigating them. This day and age, cardiac causes, or what is being recognized increasingly as cardiorenal syndrome, has become very important. So it's important to work closely with your cardiologist team, and we do that on a daily basis. With the advent of new medications that we have called SGLT2 inhibitors, GLP-1s, as well as mineralocorticoid receptor antagonists, MRAs. This is in addition to the ACE and the ARB medications. We are noticing that the progression of the chronic kidney disease is not as much, and a lot of our patients are actually showing an improvement in their chronic kidney disease. There are some patients who have particular conditions which tend to worsen the kidney function. Patients who have diabetes and high blood pressure and are doing whatever they can to manage these two conditions tend to do the best. That includes actually getting involved in checking your blood pressure, checking your sugars, and doing what your endocrinologist and cardiologist and primary care are doing. Once these things are done, we find that chronic kidney disease first stops worsening, and second, we notice that the GFR begins to trickle back up. This has to be done along with the proper lifestyle modifications. Another important aspect for our patients who are in chronic kidney disease is to not take any over-the-counter medications which their doctors are not aware of. A lot of our patients don't know that several over-the-counter medications, including cough syrups and other medications that they get online, are actually not kidney friendly. And several of our patients have been taking painkillers which are called as non-steroidal anti-inflammatory agents, NSAIDs. These are commonly things like ibuprofen, and there are several other branded products. They are actually not kidney friendly. People think that a lot of vitamins and herbal agents are natural, therefore they are kidney friendly, and that is also not true. We have seen patients who have been taking different herbal preparations, natural preparations for a long time, and after some time, even if they stop the herbal or over-the-counter medication, some kidney damage is permanent. So it's very important to be aware of what you're taking. When people ask you what medications you've been taking, the word medication doesn't mean what you get from the pharmacy. The word medication means whatever you're taking beyond what you buy at the grocery store. So this would include any over-the-counter medications, any herbal supplements, anything which is not considered traditional food or drink. Excess of any ordinary amount of food and drink can also harm our kidneys. So we see some people taking a lot of energy drinks, or we see some people doing excessive amount of a normal food item. That sometimes can be a problem too. And that's where we work with our kidney dietitian. The kidney dietitian can actually work with you one-on-one and explain what is best for you, and the recommendation they make is in keeping in line with your individual preferences, and figure out what is you need to avoid, and of the stuff that you can take, what are the food items that would be suitable for your chronic kidney disease.
There are two different types of dialysis, right? Dialysis through the blood, right? This is the one that we commonly know, which is called hemodialysis. It's usually done via an access, so that's where you make a connection so that we can connect the machine to you. So the most common one is the ones that we all see for our patients. It's called a fistula, right? So basically, you're connected to the machine. The blood moves from you into the machine cleans the blood and sends the clean blood back to you. Besides removing the toxins, it also can remove any excess fluid as well, okay? That form of dialysis can be done in the unit or in the dialysis unit, which is common, and then it can also be done at home. We can train you to do this at home as well, okay? Speaking of home dialysis, the more common dialysis done at home is called peritoneal dialysis, where the dialysis is done using the lining of our abdomen as the filter, okay? Now, how we decide, besides everybody gets referred for transplantation, okay? That's my motto. How we decide which dialysis is best for the patient is through shared decision making. We discuss each modality, and then based on the patient's lifestyle, what they're expecting for themselves, how much help they have at home, and what they think they can also manage to do themselves, that's how we decide whether it's going to be hemodialysis, which is through the blood, or peritoneal dialysis through the abdomen at home, or hemodialysis at home, okay? Now, it does not mean that if you start on one, you can't switch to the other. You have free reign to choose based on how your life changes, and that's what makes it also so flexible.
And it runs at a certain time. Typical duration is about 7 to 8 hours overnight. So in the morning, you're done and you have all your days free. A lot of our patients who are working and want to continue working, they prefer this because it also gives you the flexibility to travel. The other home dialysis option we have is the home hemodialysis, wherein you would have a fistula in your arm, and you could even start that with a catheter under your collarbone, and you would do dialysis 4 or 5 times at home every week, and typical session is anywhere between 2.5 to 3 hours. The machine is much smaller than what you see at the in-center dialysis clinic. And the next option we have is go to a dialysis center in person 3 times a week. So you would typically be going either Monday and Wednesday or Friday, or Tuesday, Thursday and Saturday. And here you're there for 3 to 4 hours and getting your blood cleaned. And typically they would give you a particular time of the day that you need to arrive. We do have a social worker as well as a registered dietitian. They would help you set up your transportation to the dialysis clinic and back, and also help you with your medications. A lot of the medications now are actually provided by the dialysis clinic, and all of what I've just mentioned is typically covered by insurance companies. So whether it's kidney transplant, whether it is home peritoneal dialysis, home hemodialysis, or coming to the dialysis center 3 times a week, and the transportation is typically covered by insurance companies. And we do have a licensed clinical social worker who can help review all of this ahead of time in person with you, so that way you're aware of the schedule. And a lot of our patients do have financial concerns, so we can address all of your financial concerns ahead of time, and that way it can be a procedure that you are aware of and are prepared for.
So our job as nephrologists is to find and communicate with the patient so that we can do the dialysis, whichever dialysis modality, safely and efficiently. Doing dialysis at home have its advantages, because if a person is functional and they want to do dialysis at night and not go to a center, spend a few hours going back and forth every day, that is a good modality to be considered.
If you're starting home dialysis, what happens is that you're going to be getting training for several days, if not a few weeks, in the dialysis center. So that time you get to meet other members of your care team, including the registered dietitian, the licensed clinical social worker, and your nephrologist. And there everything is set into motion. You kind of learn how to do dialysis, and your questions are answered, and you get clarity on your care plan. For patients who are coming to the in-center dialysis, on your first visit you go over the paperwork to understand what is going to be done, and then in the next several days you meet your licensed clinical social worker as well as the registered dietitian. It's important to set aside some time to meet with them, because that's when they get to learn about your background and your particular situation, so that they can tell you all the resources that are available. Our goal is to just use dialysis as a bridge to get you from where you are now to transplant. And during that time, it's very important to keep your body healthy. And if your body is not healthy, many times lead people to actually be denied for transplant because their body is not healthy enough anymore. Or even if they get transplant, in general, they don't do that well, because for several years, many chronic conditions, they may have had diabetes, high blood pressure, heart conditions, vascular conditions, high phosphorus, weakening of the bones. They kind of kept going on and have taken a toll. And even after you get a transplant, whatever you had before transplant stays back. So I see that sometimes in our transplant patients is conditions which they had before but were not managed properly, and they have these consequences and sequelae which are unpleasant to say the least.
For dialysis patients, part of my discussion at the beginning, and even as we go through the process, is to reassure patients that within the dialysis units and within our resources is that we can provide the patient with social support. If there is any issues with transportation, whether it's problems that the patient gets through dialysis, and if needed, sometimes we can be flexible with the schedule, so it's either done early in the morning, later in the afternoon. So the process or being a patient on dialysis is not as scary of an experience as it appears. because the patients usually build a good relationship with the staff and the social worker, the dietitians. So it's very reassuring for patients and to know that they're not on their own. They usually have very broad support system through every aspect that they will go through dialysis.
What I tell people when they are about to start dialysis or when they are on the verge of starting dialysis, I always tell them that this is a step forward, and I recommend what's best for them, if it's home therapies or if it's in-center therapies. And I always tell them that there is always a possibility of getting a kidney transplantation after starting hemodialysis if the person qualifies. So I always try to encourage them to think that this is a positive change, that they will feel better, that many of the problems that the patient may have, including excess water, excess, symptoms of kidney failure such as nausea, not being able to eat well, all these things will get better as the person starts getting dialyzed, because the dialysis basically cleans all of those waste products and makes the person really feel a lot better.
The dialysis catheter under the collarbone it's a procedure which typically lasts about 45 minutes to an hour. Is done either in access centers or in the hospitals. They numb the skin and they place the catheter. The catheter is actually available for use immediately. One of the caveats of having that, what we call as a tunnel dialysis catheter, is that the dressing has to be kept clean and dry, and we cannot take a shower. That's why we like to avoid having a tunnel dialysis catheter. And a lot of our patients who are approaching stage 5, like they are still in stage 4, we refer them to a vascular surgeon. So what a vascular surgeon does is that they surgically connect one of the veins in the arms, either below the elbow or above the elbow, to the artery. So the artery is the tube of blood which is carrying the blood from the heart. The heart is the pump, and the blood is coming, and then it goes into the vein back to the heart. The vein, getting this high pressure blood, becomes dilated, gets a little bigger, and it takes about 6 weeks to get bigger. And that's the portion of the fistula that we can use for hemodialysis. It's important to get to see the vascular surgeon, because the first visit that you have is what we call as the consultation, and then from that time the surgeon's team schedules the procedure for the surgery. Occasionally they may need clearance from your lung doctor, heart doctor, or primary care doctor to get the surgery done. So that can also take time. And from the time you actually have the surgery done, it typically can take 6 weeks. One is a fistula. The other one is that occasionally when they don't find good veins, they can put in what is called as a graft, arteriovenous graft. So a graft is like a rubber tube which is used to connect the artery to the vein. And sometimes they are available for use sooner than the fistula. But both of them do the same thing. From a kidney doctor's perspective, we find the fistulas are longer lasting, very seldom, if at all, get infected, and just serve our patients better. So we prefer fistulas, but for the patients who can't get a fistula, sometimes the vascular surgeon will place a AV graft. And once the AV graft or fistula is ready for use, then the patient can get hemodialysis from it. For our home hemodialysis patients, it's not a big deal for them or their caregiver to learn to cannulate the AV fistula or the graft. By cannulation, I mean placing the needles, because we have a numbing cream which if you put 30 to 60 minutes before your fistula is cannulated, then the skin becomes numb and then it works out. The best part of having a fistula or a graft is you don't have a catheter. So you can go swimming, you can take a shower, get into the pool, depending upon where you're living and how much of a wait time it is to see the consultation and then get all your clearance for your surgery. This all needs to be planned well in advance. So you may notice that your nephrologist is wanting you to get a fistula or asking you to get a consult done while you're still in stage 4 in order to get it done in a timely manner and to avoid placement of a catheter under your collarbone. We just need to get the ball rolling a little bit sooner, because if we don't, we do see patients who start going into stage 5 and start having complications of untreated kidney failure. And then at that time, the only option available is to put the catheter under the collarbone. So just because you have a mature fistula doesn't mean that you're going to get on dialysis sooner than you should. But it does keep you out of the hospital. It does keep you from having an extra procedure.
Whenever you have chronic kidney disease, besides controlling the illness that caused the kidney disease or contributed to the kidney disease in the first place, the diabetes, the high blood pressure, we also have to think about our lifestyle modifications. So this includes ensuring adequate fluid intake. Typically, I would say, 1.5 to 2 liters of fluid per day. So this also, it's not just water, it's tea, juice, the things that are liquid that you consume per day to ensure you stay hydrated or drink to thirst. Secondly, we want to think about other things. So whenever you have kidney disease, we take your blood test frequently and we look at all of your electrolytes, the sodium, the potassium. We always recommend low sodium, which is 2,000 milligrams of sodium in your diet for the day, because it also helps with reducing fluid retention and with blood pressure control, okay? And of course, if your potassium is on the higher side or elevated, then we also recommend avoiding foods that are very rich in potassium, like potatoes, tomatoes, avocados, okay? Then we also think about, even though we all need, calcium, phosphorus, the phosphorus can sometimes cause us to have, bone disease. The kidneys are also responsible for maintaining that mineral. So if it is elevated, then we also have to, avoid phosphorus-rich foods in our diet as well. So it's very important, besides the typical, exercise, which is usually, 150 minutes of aerobic exercise per week, low sodium, which is 2,000 milligrams of sodium in the diet, low potassium, which is also 2,000 milligrams of potassium in the diet, right? And ensuring adequate hydration daily.
Diet has definitely been under-recognized for our kidney patients, including excessive protein intake. Excessive protein intake has become a fad currently through social media and other reasons, and it has never been shown to be helpful. There have been several research studies which show that high protein diet can actually hurt the kidneys. So it's important to eat a more natural based diet, food cooked at home with ingredients purchased from a regular grocery store. You've got to actually read the labels of what you're buying. If the labels have long words and chemical names and ingredients which you don't pronounce or know what they mean, best to avoid them. And second, actually cooking. We need to start cooking and reclaim our kitchens, and food made at home is invariably much better than food which we purchase from outside. Preserved food or food coming out of a vending machine or food which has a long shelf life of 3, 6, 12 months is not good for our dialysis patients, typically because it is high in phosphorus, it's high in salt. And when we eat things which are high in salt, it does make us thirsty. And when we become thirsty, we do invariably, even unintentionally, go above our fluid allowance. So that needs to be avoided. Secondly, when we are on dialysis, we have to be making sure that we are eating a well-balanced diet, taking a multivitamin with it, and again continue to follow a diet that is in sync with our endocrine diabetes doctor, with our cardiologist's recommendation, and whatever was going on before dialysis is still going on after dialysis. So it's important to tell all of that to your registered dietitian so that the registered dietitian can make an individualized diet plan for you. And they do lab work at the dialysis clinic pretty often, and a lot of the problems are identified, like say if the phosphorus or the potassium is running high, or if there is too much acid in your body, then those problems can be rectified. We can fix those problems, but they do require a change in the lifestyle. And primary change in lifestyle from the continuum of chronic kidney disease to dialysis is a change in our diet. Whether they are on home dialysis or going to a dialysis center, we do recommend about 35 to 40 ounces of fluid intake, and also avoiding a whole lot of things like sports drinks and other manufactured drinks, water, some juice, milk is okay, but try and stay natural as you can. So when somebody starts dialysis, one of the big concerns for the patients and their families is our life going to still be the same? Can they attend family events? Can they attend the baseball game? Can they attend the wedding this summer? And my philosophy with dialysis, having done this for more than 2 decades, is we want dialysis to fit into your life rather than your life fitting into dialysis.
So if you do in-center dialysis, for example, we typically just ask that you give us a couple of weeks notice so that we can, identify the dialysis unit that is close to where you're going, so that we can set up for your dialysis for you to go to 3 times a week like you usually do here, and that's usually set up before you go, so that's no problem. For peritoneal dialysis, again, just notify us earlier, and then we ship your fluids and all of those things to where your destination. Okay, I'm telling you, we've had a patient who went to, I think it was Peru, and he got his PD. He notified us like 2-3 weeks before, got his PD supplies, everything shipped to his hotel. So it doesn't upend your life. All that's needed, of course, is some planning beforehand. Okay, now as you're on dialysis, you will always have continued education, support from the dietitian, support from the social work, support from the dialysis staff and your nephrologist. And so we'll continue to work with you through it so that it's not a horrible experience and for you, because it is life-changing. That I can definitely say, but hopefully for the better.
The biggest benefit would be to choose home dialysis, because with home dialysis you can actually carry your peritoneal dialysis machine or even the home hemodialysis machine with you. The insurance companies typically provide for payment to have these dialysis supplies delivered to you anywhere in the country, coast to coast. So as long as you tell us, say 6 to 8 weeks or even 4 weeks in advance, we can make that happen. And you can get your dialysis done wherever you're going, at the beach, or if you're going to a big city. Even for our dialysis patients who are coming to the dialysis center 3 times a week, we can arrange for dialysis for you if you're going to Florida or any other place in the country. There are several dialysis clinics, and we ourselves get many transient patients who are visiting their family for the holidays or in the summertime. So we are able to accommodate all of that. Many other patients have concerns whether they can continue their employment, or if they were planning to work, can they start work? And the answer to that is yes. I myself am a big proponent of people, our dialysis patients, continuing to work, and we work with the insurance company as well as the employer to get the kind of hours that they want, that you want, and the dialysis fit into the rest of the time. It's important that we work with our social worker, because our social workers are skilled and they know all the options that are available. I personally enjoy my work as a kidney doctor, and I'm glad I'm still getting paid for it, because even if I didn't, I would still do it. Each person's work brings value beyond money. I encourage all of my patients to continue working. An important thing I wanted to share with you is that we need to take control of our health. For those of us who have high blood pressure and diabetes, we need to understand that these two conditions lead to need for dialysis in more than 90% of Americans. So we really do need to get involved in managing our diabetes. We need to understand how the sugar patterns are going. We need to follow with our primary care doctor, and if they refer you to a diabetes doctor, we need to see what they have to say and get your glycated hemoglobin or HbA1c below 8 or close to 8. It's actually important to understand that the diabetes is not just damaging your kidney. The diabetes is damaging the eyes. It is causing nerve damage, heart damage, vascular damage, and many times these damage parts of our body, organ systems, they don't recover. They don't recover even after diabetes gets better controlled. So this is where that ounce of prevention is worth better than a pound of cure is actually applicable. So it's important to take control of the diabetes, and similarly for blood pressure. If we need to take medications and then check our blood pressure, make sure that the blood pressure is within the guidelines that your doctor has recommended. If someone has diabetes and blood pressure together, then it's very important to get the blood pressure even lower. And a lot of patients who get a kidney problem or chronic kidney disease from just diabetes, even if they did not have high blood pressure before they got CKD, they begin having high blood pressure after they get CKD. So a lot of these medications which your doctors may prescribe may appear to be a little bit on the aggressive side, but taking a combination of these medications is important, because a lot of medications overlap in their efficaciousness and they work together with each other. And now we have more and more data to show that people who have blood pressure of say 140/90, do much worse than say blood pressure of 130/80. So the data is there. We need to take control of our health. If we want long-term improvement in our chronic kidney disease and we want to avoid heart damage, it's so important to be aware. And when we are aware, then we participate in our health, and that leads to better outcome. A lot of our patients who have heart disease, that starts with high blood pressure. And a lot of my cardiologist friends say that inadequately controlled high blood pressure leads to heart conditions, and then heart conditions take a life of their own. So many times when we are engaged in our health and we take control and we participate, and when participation means showing up at your primary care doctor's office on a regular basis, doing the lab work that they want you to do, and then seeing the specialists as needed. So it's basically a holistic view of your health until you are willing to participate in it, the benefit that you can get are less than otherwise. So I think I would urge everybody to get engaged with their health and make conscious choices. And I'm not just saying it like that. I think it's important to follow up and use all the resources that you have. Many times we have resources, we have health coverage, we have access to doctors and other healthcare providers. We have to be good consumers of these resources, because this is the body that we have, and whatever conditions and complications it develops, it just stays with us for the rest of our life. So many times people find out later on, like, chronic kidney disease is a silent condition, hypertension is known as a silent killer. If we don't know about it, then the consequences of the damage has already happened. And a lot of this damage, unfortunately, is not reversible.